Hello, I'm very pleased to be discussing this. I am Professor of Medicine in Newcastle, but my main thrust throughout the years has been to look after people with all sorts of general medical problems. So acute general medicine is my background, but over the years, of course, it's focused down and increasingly the research has increased. So my focus on type 2 diabetes relates to the extreme problems that I've seen it produce in my patients. I'm most pleased about this because it gives prominence to the work which I believe can be of great value to all people with type 2 diabetes. Not everybody wants to follow the precise research protocol that we used, but that was designed specifically to be practical. And so overall, winning the Claude Bernard means to me more people in the world will be able to be helped with their type 2 diabetes. The concept of remission of type 2 diabetes came about because of my work over decades of trying to find the cause of type 2 diabetes. And we learnt various items about what was happening in muscle, what was happening in liver, and then what was happening in the pancreas in the background. And it was a puzzle because how did these pieces fit together? And then it all came together in 2006 when I put forward the twin cycle hypothesis. Now, this proposed that if we were to reduce calorie intake so that body weight went down substantially, then possibly we might see all the pathways which I envisage going into reverse. We would reverse those processes and perhaps get remission of type 2 diabetes. But the main question was about the cause of diabetes. Our first study in this line was published in 2011, and that was absolutely extraordinary. We observed stopping medication, starting the diet, which was designed really by my patients because it was on the basis of what they told me. So it had to be short, it had to be free of problems and difficulties, so we did that. And we saw that all the processes indeed went back to normal, and we could measure each of those. And to my astonishment, the diabetes went away. And so that began the era of remission and how to achieve it. What we showed very dramatically was that it was dependent upon the extent of the weight loss and the duration of the diabetes. So if the diabetes was too long in duration, then we could get the liver back to normal and the fats in the blood would fall. That's fine. But in those people who did not achieve remission, it was because the pancreas had been exposed too long to very high concentrations of fat in the blood, triglyceride fat in the blood. So we took this forward and then started researching remission itself in direct. And then the big direct study showed it was feasible, dramatically successful, and we've gone on to do further work. But that's really what remission means. That's where it came from. It was a research thrust to understand the cause of diabetes, find the cause, and we can get rid of that cause. This is a very good question. I would say, firstly, that all people developing type 2 diabetes should be told that it is possible to get rid of their diabetes if they lose sufficient weight. How they lose that weight does not matter so much, but developing the research tool that I did to achieve rapid weight loss has been shown to be effective, applicable to large populations, and compatible with long duration remission of diabetes. But we need to learn more about this phase of keeping diabetes away, that's for certain. But going back to how doctors may use this, yes, offering the opportunity to achieve remission. Not all patients will take that up. They sometimes want a quick fix, but sometimes it's the wrong time in their life. They might have a lot of worries, problems of the moment, and so they just want something easy. And fine, we can use the information to decide which medicines to provide. So the important thing is medicines that will achieve weight loss. So the ones that come to mind are the SGLT2 inhibitors to allow renal loss of glucose and fall in weight, and of course the appetite suppressant drugs. They're referred to as GLP-1 agonists, but in a way that distracts attention from their most important function. They do nothing directly on the pancreas, to our knowledge, but they affect the appetite. And that is wonderful. For the first time, we have the opportunity to use a medicine to dial down this strange matter of appetite, which is given unequally to different people. Some people take every opportunity to eat. Some people, perhaps like me, don't particularly mind not eating for a while. So seeing that we can use that information in the clinic, looking after the individual patient in front of us, that's very exciting. So the choice of medicines, those that achieve weight loss would be first line. But coming back full circle, the most important thing is to inform the person about this matter of weight loss, even if they have a normal body mass index. And our most recent study shows that even in the normal BMI range, if a person develops type 2 diabetes, they are too heavy for their own body. No one else's body, their own body. And that is so important because all the big studies of diabetes, of course, look at the common factor of being overweight or even obese. But that's not the cause of diabetes. The cause of diabetes is to have more fat than a personal threshold. And especially in China, people tend to develop type 2 diabetes at relatively low body mass index. It's so important that doctors know that even so, that person with a body mass index of 20, 19, but type 2 diabetes, they need to lose weight too. So I believe this work has wide application, so important for doctors to learn about this for the benefit of people with type 2 diabetes. This is a very, very important question. And it is important to say firstly that for much of my career, I was in charge of the clinic for medicine in pregnancy. So this is my clinical work. Because of what I saw in gestational diabetes, I thought that we should also be looking at low-calorie diet in pregnancy. In pregnancy, a very special state, firstly, we have to look after the health of baby, and the lowest number of calories that we could use and still have mother to be adequately nutritionally fed was 1,200 calories, and so we used that diet in a study called WellBabe. And in the WellBabe study, with people developing gestational diabetes at 28 weeks, a period of weight reduction brought about half a kilogram per week weight loss for the 4 weeks of the study. Only 4 weeks, from about 30 weeks gestation to about 34 weeks gestation. And we showed that this dropped fasting glucose, it needed less drugs and no insulin. So that study was important, but it leaves open big questions. So having understood the basis of this, and in that study we measured fat in the liver during pregnancy. At the time, it was very controversial to use magnetic resonance MRI scans in pregnancy. Now it is routine. But we used 3 Tesla, very powerful MRI in pregnancy because we knew it was safe. And we showed, somewhat to our surprise, liver fat levels were not that high in pregnancy, in gestational diabetes, but with the diet they fell. And they fell back to what they should be, because it seems in pregnancy liver fat levels go down as part of the physiology of pregnancy. But in gestational diabetes, they don't go down far enough. So we had our understanding, we had to do the study. And Claire Meek, working in Cambridge, put together the digest study that I've had the privilege of advising on. And we show that weight loss is very good in pregnancy. But let me explain. In digest, we wanted to use my 1,200 kilocalorie diet and compare it with a control diet. Now, ideally, I would have liked to have used 2,400 because I thought that would be about what women would take. But other experts said, no, it should be 2,000. Okay, well, we did that. And what we showed was, first of all, the group of women recruited had a very high BMI, 36. I think the midwives who were recruiting people tended to ask heavier women especially. So we had a very heavy group, and both diets caused weight loss, a lot of weight loss. So we didn't show a difference between the groups. But when we look at those women who lost weight compared with the women who didn't lose weight, there are huge differences in everything. Macrosomia, but no increase in low birth weight. Less of all the complications of pregnancy, much better control, and less need for insulin. Even in the original blind study, where we had similar weight loss, there was much less need, highly significantly less need for long-acting insulin. So, putting all of this together, if a woman develops gestational diabetes, she should attempt to avoid any further weight loss and ideally lose a little further for the whole of the rest of pregnancy. But there is a very important message for all young women. If they want to have the best pregnancy with the best outcome for their baby, getting weight down to their personal ideal weight should be done before pregnancy. Now, we need further research evaluating this, but we have to open our eyes and look at the weight of pregnancy age women just now, much heavier than in the past. And this is a big problem throughout the world, but I know it's also a problem in China. Young women don't realize that they are too heavy. So this has to be evaluated, and it's a call for further research before this important message can be spread out. So that would be my main message for the future, for doctors to look at this question. Yes, how to best define the best weight for pregnancy. I would say, first of all, there is still some work to do to get all doctors and researchers to understand that type 2 diabetes is a condition of more fat than a person can bear in liver and pancreas. There is no other cause. Of course, it's in genetically predisposed people, but we cannot change the genetics of the population. That's there. And I say this because there are a lot of confusing ideas about topics which are almost certainly irrelevant. So there's inflammation, there is islet amyloid, there is antioxidant stress, there is the microbiome. when it comes down to a hard science, there is no evidence for these, but huge research funding is still being pumped into these areas, and sooner or later it's got to be realised we have to concentrate on the important things with a huge effect size that are practical to do for the population. So that's my first point, firming up on what we already know. My second point would be a matter that you touched on earlier, that is maintaining weight loss, this difficult matter of avoiding weight regain over the years. Certainly in Western Europe, people tend to gain 0.5 kilogram a year on average. So that stacks up, and so people aged 50 and 60 on average have gained quite a lot of weight. Weight gain in adult life is fat. It's not more brain, it's not more liver, it's fat. And this is something which needs to be explained. So a person of 50 should not look around their friends age 50 and say, I'm the same, so I'm okay. They should look at their photo when they were 20 to see, am I still the same shape? Okay, that's very important. But how to achieve that? Certainly we've been able to demonstrate that we get reasonable 5-year results from direct, but reasonable, not good enough. The 5-year follow-up in direct was deliberately low cost. It had to be almost zero cost to the NHS in order for it to be feasible. And because of that, we now have an NHS programme. That's very good. But it could be improved. In direct follow-up, people just saw a nurse every 6 months, every 3 months. And that's okay, but it's not intense enough. Individuals fed back to us they would have liked to have interaction with other people keeping the weight down. It's possible that the development of apps could help individuals monitor things, but also there's a matter of realising that occasional weight regain will happen during stresses of life. So if weight regain happens, it's not a failure. It's merely a matter of recognising when possible, when the stress has settled, then weight loss is needed by dietary means or by other means. And that's quite exciting because there are potential for maybe using the new appetite suppressant drugs to help regain the weight. We need to develop strategies for this very important point of avoiding weight gain, because the beta cell does not go downhill by itself. It only goes downhill when the cause of diabetes is present, that is, too much fat. Take away the fat, the beta cell will stay level. It will recover at first and then stay level. It may have been slightly damaged already, it may not recover absolutely fully, but it will not go downhill, provided people keep the weight steady. So, big research questions. How to do this effectively? And there are so many ways that we can look at this. The groups, the apps, the use of medication strategically to help with intermittent weight loss. And I'd add just one thing. There is a rumour in the literature that what is called yo-yo dieting is bad for you. So people lose weight, put it on, lose weight. That is nonsense. There is no solid evidence that yo-yo dieting is bad for you. And now we have absolutely clear evidence for that. In direct, many people in the weight loss group put some weight or all the weight back on over 5 years. What happened to their rate of complications? Now, the rate of complications was more than halved in the intervention group by intention to treat. So there was no sign of any adverse effect of yo-yo dieting. And if we look to other trials, to the look-ahead trial, and look at the 12-year data recently reported, analysed by whether people achieve remission for just transiently or for 4 years or more. Remission for more than 4 years dramatically reduced heart disease rates and chronic kidney disease, but even achieving remission on one occasion produced major benefit. Now that group will have had yo-yo dieting, major benefit. We need to put a stop to this counterproductive rumour that yo-yo dieting is bad. What matters is getting the weight down, certainly from time to time, and striving to keep it down. So I hope that answers your questions about the necessary future of research into this very important problem.